Okay, so today's webinar's topic is the treatment of central serous chorioretinopathy with TruScan 577 with SP mode. My name is Yoko Miura from Germany in Lübeck. Sorry. So let me introduce myself a little bit. I'm from Japan and studied medicine in Japan. I started ophthalmologist in Japan and came to Germany about 15 years ago. I made a license in Germany too, and I'm working now as an ophthalmologist in University Hospital in Lübeck. And at the same time, I'm leading a research laboratory in the University Institute of Biomedical Optics as a reader of the retinal photobiology group. At the beginning, I was very much focused on the retinal pigment epithelium RPE and health and disease, and later on came to the topic laser tissue interaction at the RPE. For example, what happened if the RPE cells are heated, or what happened during wound healing, and so on. And since last year, I'm using TruScan and treating macular diseases with patients in the university hospital. So let's start with basics first. We can look at retina first. So as you know, retina is a semi-transparent membranous tissue with about thickness about 200 to 400 micrometer. And photoreceptors, I want to make, so photoreceptors here receive the light signal coming from here, and this signal is converted to the electric signal, and this signal transferred to this way and go to the brain. So for today's topic, what is important is macula. Especially macula is important. So macula is a central area of the posterior part of the eye, diameter about 5.5 millimeter. This is a little bit lower than optic disc. And in the center of the macula, there is an area fovea. Fovea is about 1.5 millimeter diameter. And in the center of the fovea, there is a zone without any vessels in the healthy eyes. It is called foveal avascular zone. This is about 0.5 millimeter diameter. Around the fovea, we called parafovea up to 2.5 millimeter, and around parafovea up to 5.5 millimeter, it is called perifovea. If you look at the slice of the retina, it is look like this. Retina is composed of many different cells and nerve fibers. And at the last layer is called pigment epithelial cells, RPE, and here is the photoreceptors. In the fovea, it looks like this. It is like a foveal pit, and also we call also foveal depression, and so on. And here, if you look closer, there are a lot of yellow pigment. It is called macular pigment, main component of lutein or zeaxanthin. They are focused especially on this area, and they are protecting the retina, especially photoreceptor and RPE, from the UV light or blue light. So today's topic is central serous chorioretinopathy, CSC. So CSC is one of the major diseases of the macula. It occurs mostly in the adult in their 20 to 50 years old, and many male, but female also recently, especially the number of the female patients are also increasing. In this disease, fluid accumulate in the subretinal space. It means between photoreceptors and RPE, this area subretinal space. The fluid is accumulated and it makes serous retinal detachment. How patient can see is different. Some patients say just don't see very well, for example, blurred vision or distorted like wavy, or hyperopic vision, it means your glasses doesn't fit anymore, or micropsia, it means everything looks smaller, or disturbance of color perception, or loss of contrast, or sometimes dark spot. Some patients say dark, some patients say very bright. So there are different symptoms. What is the reason? What is the cause or risk factor? There are different factors it's considered. Many people know already that this is especially stress is related disease or type A personality, sometimes but hypertension or exogenous glucocorticoid steroid therapy can trigger this, or hyperopic eye, it means short axial length is known to be a risk factor, or sometimes inside kidney disease, sometimes psychological sleep disturbance or depression medication can also induce, and pregnancy or infection or genetic factors. This is very multifactorial. So here, the changing slide is a little difficult. Okay, so diagnosis. Diagnosis of CSC is not so difficult, but it's very important to make a differentiate diagnosis in order to choose the appropriate treatment. One of the most important is OCT, optical coherence tomography. Many of you already know. So with OCT, we can see very well a ciliary retinal detachment like this due to the accumulation of fluid, as we saw before. And we can see that this area very homogeneous and also very low reflectivity in OCT. It's not difficult to find this. And recently, of course, it's very well known. This is important to see the choroidal thickness. Choroid is below RPE here because this disease is also sometimes related, strongly related to pachychoroid, thickened choroid, although it's not always. So in order to see this, we can use the OCT with, for example, enhanced depth imaging, EDI, method, or sometimes you can use swept source OCT and so on. If you can see the choroidal thickness, it's good. And another very essential method is fluorescence angiography. This is very important because in this disease, you can see typically dye leakage from the part of the weak RPE barrier function, as you can see here. So this is fluorescence angiography. You can see this part after the time, you can see the dye leakage where the RPE barrier function is weak. This leakage sometimes local, just one, or sometimes diffuse, sometimes just one, sometimes multiple. So next, indocyanine green angiography, ICGA, is also important, especially in order to find the choroidal neovascularization, CNV. If you see the active CNV, sometimes you need other treatment. Therefore, it's important to exclude the existence of the active CNV. So nowadays, we can also appreciate OCT angiography, OCTA. This is, many of you already know, this is a method to see the vessels without any injection like fluorescence angiography. This can be also, of course, utilized to check CNV. For example, the patient has an allergy in the fluorescein, and we cannot conduct fluorescence angiography. You can at least conduct OCTA. So this is clinical cause of CSC. It's very often the fresh case is very much self-limiting. It's very well known and shows spontaneous resolution in 3 to 4 months. So therefore, many patients, especially young, the first time it's young, they're young, and doctors also say, okay, we don't have to do anything. But however, very importantly, recurrence of, unfortunately, very often, within 12 months, about 30 to 50%. And this recurrence may solve again, but may cause persistent visual disturbance. So if you recur many times, then RPE slowly damaged and show diffuse leakage. So this is the beginning of the chronic. And the real chronic cases is reported about 5%, But not only such a very typical chronic cases, there are many patients who has a very often repeated recurrent cases. And if you get older and with multiple recurrences and persistent subretinal fluid, then visual prognosis became always worse. Therefore, it is very important to treat as early as possible and to reduce the duration, the time duration of the serous retinal detachment. So treatment, we are getting closer to treatment. So traditionally, so we did before always photocoagulation at the leakage point, which we could find in the fluorescence angiography. But if the leakage point is very close to the fovea in the center part, we didn't do anything, because if we do photocoagulation, it means we see very white spot. It means destruction of photoreceptor. So this means we see very irreversibly dark spot in your center of the visual field. This is absolutely we have to avoid. So therefore, we didn't do the treatment in those cases and just observed. So, but last 10 to 15 years, there are many possibilities. Many possibilities have been introduced, and patient quality, visual quality became better. For example, anti-VEGF intravitreal injection could be used, could work sometimes, or sometimes oral administration of medicine like eplerenone or acetazolamide have been used. I explained about this medication later on a little more in detail. Or sometimes eye drop with NSAID. And recently, more as the most effective, except our method, photodynamic therapy, has been also reported very often. But all of them are off-label use. So now we have a possibility, very good possibility, to use a new laser treatment, minimally invasive laser treatment. So with this treatment, we can treat sub-threshold, so to say, so sub-visible laser irradiation using a technology, new technology as microsecond pulse, like used in LightMed SP mode. So now we came to the SP mode treatment. Let's have a look what it is and how it works and how we can use it. So first of all, I can show this maybe very well-known schematic description. This is a difference, a comparison between CW, continuous wave mode, and SP mode. In the continuous wave mode, the laser is always on during the irradiation time, for example, 200 millisecond one irradiation time. But in SP mode, microsecond laser technology, so they can repeat on and off time, just like pulsing during irradiation. For example, and typically this repetition is 500 hertz. It means one cycle on and off is every 2 milliseconds. This is almost fixed. So this is why, so we can think, for example, if so the promotion on and off time is called duty cycle. So proportion. So for example, if the duty cycle is 10%, 10% duty cycle means on time is 10% of 2 milliseconds. It means 200 microseconds, and 90%, 1,800 microseconds is off. This is repeated as long as you want to irradiate, for example, 200 milliseconds. If 200 milliseconds, it is repeated 100 times. So due to these differences, what happened is in this SP mode, the temperature it decreased during off time to some extent. Therefore, the total temperature increase is much, much lower compared to the CW mode at the same power settings. What we want to do with this treatment, why we want to use such a low power, low energy treatment? Because we want to treat RP cells at a local level without destroying photoreceptor cells, like we did before in conventional laser treatment. So one slide, I like to talk about a little bit physics, why RPE can be targeted with laser. So many of you, I think, know that laser is the best way to target RPE exogenously, because the most used laser and laser light from 500 to 800 nanometer wavelengths very well penetrate through the ocular media and absorbed very well mainly in the melanin in RP cells. Very high absorption coefficient. Therefore, whichever the wavelengths we use, the heat center is RP melanin. So always, whichever the wavelengths we use, the heat center is just RP level. This is very old but nice study. But for your information, if we use a longer wavelengths, the light goes through a little farther, then the heat center becomes a little colloidal side. But whatever wavelengths, as I said before, RP melanin is the center of absorption. So therefore, we can target the RPE with this laser 577. So the next question is why we want to treat RPE. This is, of course, fundamental question. So I can explain you a little bit about what RPE is doing. So RPE is the last layer of the retina, actually most backside of the retina. This is one cell layer, but very important cell layer. So for example, they are doing, for example, light protection with melanosomes, or sometimes or vitamin A cycle is very important, and water transport. It means here, if the water is accumulated here, it pumped out from this to here. Or sometimes tight junction is very important to prohibit some substance go from here to here. And most importantly, phagocytosis is photoreceptor outer segment. It's very important to renew the photoreceptors. So all of these functions are very essential for the retinal function, whole retinal function. So it means RP is working like this. So you can see in this picture, RP is just one layer at the backside of the very big retina, but it's very invisible hero, so to say. So RP supports the function of the retina. So therefore, the health of RPE essentially affects the health of the whole retina. So therefore, we want to treat RPE. And what we want to do with SP mode, therapeutic mechanism, is we want to heat the RP very mildly, and we expect the activation of the metabolisms and function of RP cells. And it can increase, for example, pump function, the water accumulation, or secrete different protein, the cytokines, which can be very positive to the retina function. And finally, we can expect improvement of retina and visual function. So you can see here in these images, just warming the partial local RP cells, and we expect the functional remodeling of the RP. We don't do any damage, but functionally remodeled. So this is the basic strategy of the treatment. So finally, I would like to introduce you 3 different cases. I just prepared 3 cases with CSC with different types and clinical episodes. So let's start case 1. Case 1 is persistent case. He had, this is guy, so it's longer than 20 months before he came to me. So let's see. And the patient is 53-year-old male. And this patient noticed visual disturbance after steroid pulse treatment due to hearing problem. As I said before, steroid can also trigger the CSC. This is one of the risk factors, known risk factors. And by his home doctor, eye doctor, he was diagnosed as a CSC on his left eye. First, he got the eye drop, but didn't have effect. And 2018, he came to University Eye Clinic, and that the visual acuity for the first time was 20/20 in his right eye, 6/20/63 in his left eyes. And he had a highly hyperopic eyes. Do you remember hyperopic eyes are very short eye axis length? This is also one of the risk factors. Otherwise, intraocular pressure or other slit lamp examination was both normal. So this is the first visit OCT image. This looks very typical CSC. And this was also diagnosed as CSC. And he started to take eplerenone. This is oral medicine. Eplerenone is, maybe as you already hear, this is a steroidal anti-mineralocorticoid. This is one of the hormone treatment, but typically used for the treatment of high blood pressure or chronic heart failure due to the elevated aldosterone. So for the CSC, it began about some years ago. It is still used. It works somehow, but it's still off-label use. So, and then what happened? So for this patient, unfortunately, didn't work at all, almost at all. So from October to February this year, last year, no complete resolution. Therefore, therapy was changed from eplerenone to Glaupax. So what is Glaupax? Glaupax is, maybe you know Diamox. This is acetazolamide, one of the diureticum, typically used for the treatment of, in the ophthalmology, glaucoma attack, or sometimes heart failure. And for the CSC, it is off-label use, but also widely used. So what happened? It seemed better than eplerenone, but still no complete resolution. Therefore, introduced for the laser treatment. Immediately, I did fluorescence angiography. This is very essential, I said. Then I saw very typical single leakage point. It's close to the fovea, about 700 micrometer. It is borderline from fovea to parafovea area. So, but there's a very typical one. So I introduce you here my strategy. So my treatment strategy is, if you see the clear leakage point, I do the subthreshold, subvisible irradiation with SP mode around the leakage point, wherever, so how much, as much as. So, and if it doesn't reduce the retinal fluid sufficiently within 3 months, then switch or additionally diffuse irradiation. Well, this is how always I do. So now practically how I do is, okay, I use again TruScan 577, SP mode, and total duration, typically 200 milliseconds, spot size 200 micrometer. I choose duty cycle so far 10%. Power titration is also very important. I do power titration at the arcade, just outside the arcade, on upper, lower, doesn't matter for me. And from mostly 200, I start with 200, and by increment by 100 milliwatt, increasing. With this patient at 600 milliwatt, I saw clearly visible spot. So therefore, I reduce just 50, then mildly visible. And again, 500, and this was negative. Therefore, I set the visibility threshold at 550 milliwatt. So divided by 2 is 270 milliwatt. This is my treatment power. With this power and other conditions, same. For example, total duration and duty cycle, everything so same, and treatment was confirmed. For this patient, as you can see here with a yellow spot, totally 11 irradiation were given around the leaking point. So during irradiation, no spot visible, no other complication was seen. So what happened? So this is a clinical course. So this is before treatment. So 1 week after treatment, no, not so big difference. This is normal. After 1.5 months, so dramatic, very nicely reduced. And the SRCF fluid was completely gone after 3 months. And until 7 months so far, no recurrence. And he's visiting us in 2 months for the 12 months control. So looks good. So how laser worked, we can see with this graph. So with respect to central macular thickness and visual acuity, I can show you. Here, left one is central macular thickness. So this is time. Central macular thickness here is thicker. During epidural time, as you remember, it didn't work so much. Acetazolamide helped a little bit, but not completely. After once laser treatment, it worked immediately, and after 3 months, complete resolution. So visual acuity was also very nice. So epinephrine, acetazolamide couldn't improve so perfectly, but after laser treatment, basically it almost always improved. I'm sorry, I have to say one thing. This is logma visual acuity. It means the lower the number, the better the visual acuity. So after laser treatment improved, and final visual acuity is the best since October 2018. So this is a case 1. This is summary of case 1. So case 1 is middle-aged man, persistent CSC, systemic steroid treatment triggered, unfortunately, and first treated with epinephrine or acetazolamide for a long time, more than half a year, almost 8 or 9 months, but no complete resolution. And in angiography, we could see localized typical leakage point. Therefore, treated with TruScan SP mode subvisibly, so it means about half power of the visible threshold around the leakage point. Then SRF fluid immediately restarted to reduce. After 3 months, completely resolved, and visual acuity also improved. So patient's comment, I can show you here, treatment was very painless, so no pain at all, and quick and very tolerable. So he was anyway very glad it worked well, and also very glad because he was now free from systemic medicines. Okay, this is case 1. Okay, now second is case 2. This is chronic case. So in CSC, there are a lot of chronic cases, therefore, so it's also a good example. Again, 57 years old, same age, same generation, male, recurred CSC for both eyes. So he had many times CSC since in his 40s. And this time again, recurred again, 2017. And he got the cataract operation in between, and due to the congenital cataract. So independent of this, he got the anti-VEGF and epinephrine for his CSC, but finally no improvement, and therefore he came to laser therapy. So visual acuity at the first visit to my clinic was both eyes 20/32. So otherwise, no particular findings, except intraocular lens and YAG capsulotomy. Everything looks stable. So this is the angiography image, totally different from the case 1. Both eyes, we can see a lot of diffuse hyperfluorescence, sometimes leakage, diffuse leakage, or sometimes window defect due to atrophic changes. This is both eyes. The first visit OCT looked like this. So the first visit, he showed a lot of findings in his right eyes. What we saw is subretinal fluid accumulation here and here, and also intraretinal retinal edema. The left eye, at that time, we didn't see any subretinal fluid, but we saw atrophic changes, sometimes thinning of the retina. It means he had before, in the past time, probably CSC subretinal fluid accumulation. So what I did is for the right eye. So left eye, at that time, we didn't do anything. So this kind of chronic CSC, and he had a macular edema. Sometimes it can be with macular edema and diffuse leakage. So it is sometimes called diffuse pigment epitheliopathy. So treatment is also not so big difference. So 577 SP mode, duration, spot diameter, duty cycles are same. Titration was also done from 200 with every 100 milliwatt, and he showed clearly visible spot at 700, 600 faintly visible. So therefore, I divided 600 by 2, then 300 milliwatt. And spacing, it means so I just put one spot diameter at least spacing, not like so next to each other for this patient. And totally 70 2 spot was done like in this sketch. And excluding central 800 micrometer, this is about 800 central part I didn't do for the safety. So this patient I could use pattern, but I didn't use because he was at the beginning especially very nervous, and his eye moved very strongly. So every shot his eye moved. So in this case, pattern is very difficult to use. Therefore, I did manually. It is not so big matter. I could do this. So what happened? So we can see the clinical course, and this is before treatment. The laser after 1 month, very nicely, SRF, subretinal fluid, is gone. And the intraretinal edema is dramatically reduced. After 3 months, again, much better. So in 3 months, we could see very good improvement, not only OCT image, but also visual acuity too. After 6 months, we didn't see big difference. But after 9 months, so unfortunately, edema appeared in the middle. So this is why I decided to do treatment immediately. Retreatment and the same strategy, like same procedure as the first time. So what happened is, after 1 month after treatment, again the edema is away, and after 3 months, the edema is much smaller, and visual acuity also become better and now stable. So now is this point. So this case, visual acuity is shown here. So he got a different treatment, as you can see, anti-VEGF, epinephrine, acetazolamide, and in between cataract operation. The visual acuity was this range. After laser treatment, visual acuity became better, and he showed now the best visual acuity since 2016. So this is very well. Then with this, his left eye, I want to show you. The left eye was always dry, but last month he showed a fluid in the middle, it's a fovea. So, but he doesn't show, of course, in this case, no leakage, no local leakage, only diffuse. Therefore, I immediately treat it like this, except the central area. The same strategy, same protocol. This time I use 250 milliwatt. Then after 1 month, very nicely, the subretinal fluid is gone. So I think the laser worked well in this case too. So this is the left eye. So this is a case to summary. So again, middle-aged man, very chronic CSC with diffuse leakage, diffuse pigment epitheliopathy it is called. And the repeated treatment, including anti-VEGF injection, he also got. And cataract operation probably induced macular edema. So this also additionally damaged. And epinephrine, acetazolamide also given, but they couldn't reduce the edema and subretinal fluid. And partial atrophic change of RPE. So this is everything look, this case very difficult. But treatment with SP mode significantly reduced the retinal fluid as well as macular edema. So, and the visual acuity also improved, so slowly. So it means retinal functionality might be the best and so far during his treatment period. So this patient also very happy so far. Anyway, treatment is very mild and very tolerable. So at least much more comfortable than injection. So therefore he's very happy. Okay, the last case. This is first episode, different from the others. So this time is female, 45-year-old female, and she noticed visual disturbance on her left eye since several months ago, and he went to the optician to make a new glasses. So then, but optician said, something strange. you should go to the doctor, and she came to the ophthalmologist and diagnosis as CSC. And doctor gave her acetazolamide to oral medication for 3 weeks, but it didn't work. So therefore, she came to the university hospital for the treatment. The visual acuity for the first visit was 20/20 for right eye. This was good eye. And the left eye, the CSC eye, was 20/25. Otherwise, IOP or lump examination totally normal. Just she showed the serous retinal detachment, CSC, at her left eye. So this is why she came to the laser clinic. So this is her fluorescence angiography and OCT for both eyes. So right eye looks very good. So left eye. So we can see very typical subserous retinal detachment at the very in the middle. And fluorescence angiography show very faint leaking point. It's not typically, mostly its typical one is a little strongly, but very faint. So if I look more carefully, the leakage doesn't seem to be so much active. And also we can see a little very faint hyperfluorescence point. So therefore, I thought this is a little bit diffuse cases. So this is why in this case, treatment, not only leakage point, an area of serous subretinal fluid was taken. This strategy was taken. So test irradiation, again, 200, 700, and her case, 600 milliwatt is positive. So how would I treat it? So I can see a little clear here, so how close it is. The closest leaky point was about 400, very close to the fovea. SRD detachment is like this. So what I did is, so this area about a little farther from the fovea center, just half, 600 divided by 2, 300. And if go to closer, a little reduced. This is my way so far. I reduced a little bit, 80 to 90% for safety. I really have to evaluate if this is really good, or if I can optimize this. So, but so far, it worked like this. So what happened to this case? So yeah, so patient came after 7 weeks. It took a little bit longer. Normally I see one month later. The patient came, okay, everything's good, perfect. It worked very well. Then we did OCT. Then actually retinal fluid was increased, a little bit increased. So, okay, what shall we do in this case? We waited. So, because subjectively better, and I say later, at least it is recommended to wait until 3 months. So we waited. Then after 16 weeks, so it's a little later, actually 12 weeks was planned, but due to Corona problem, it became 16 weeks later, but subretinal fluid was completely gone. So subjectively, of course, still very good. Patient looks perfectly, she said. If I see, I shall check autofluorescence, no scar formation. So it means the irradiation was really sublethal. So this is a case 3 summary. This is female, 45-year-old, first episode in her life. So it was but already persistent CSC, it can be called, longer than 4 months. And very mild leakage. It means it's not so active. It's maybe this was diffuse leakage. Therefore, from the first time, diffuse treatment was taken. And yeah, if this is closer to the center, so far reduced power was taken. And 7 weeks later, subretinal fluid was increased, but the subjective feeling was better. So we waited, and after 16 weeks later, SRF was almost completely resolved, completely resolved. So yeah, question is better visual acuity despite increased SRF. It could be effect of laser therapy, but it should be still open question. But anyway, what I wanted to say with this case is it's very important to be a little bit patient. Recommended is at least 3 months to wait after treatment. Some patients show much earlier improvement, but not always. So from 1 to 3 months, this is very big range. So therefore, at least 3 months after 1 laser treatment, unless it's big, so very significant worsening occurs. So now case 1 to 3 is finished. So I want to show you conclusion of all cases. And with SP mode, different types of CSCs can be safely and effectively treated. For example, acute case, persistent case, chronic and recurrent case, and localized leakage point or diffuse leakage without edema, with edema. Of course, difficulty is different, of course, but every case can be indication. So far, I use 10% duty cycle. So there are a lot of discussion, but at least this can be used completely safe. Of course, you need to choose the power, appropriate power. So therefore, test irradiation is recommended. And for CST treatment, from my experience, about 40 to 50% of the power for the very visible spot, it means visibility threshold at the test irradiation, seems to be effective and safe for the treatment power. So no scar formation occur with these power settings. And finally, it is very important. So it's very important to be very patient. It takes about 2 to 3 months. And sometimes subjective improvement, for example, I see better or with metamorphopsia is gone a little earlier, mostly in acute cases, but sometimes other way around. So therefore, it is recommended to wait at least 3 months after 1 laser treatment. So final conclusion. So SP mode for retinal laser therapy enables the treatment, the macular treatment without risk of scar formation and scotoma, and no ocular or systemic side effect. And a repeated treatment is possible if needed. And very importantly, it can reduce patients' physical, mental, and economical burdens through repeated injection or taking systemic drugs. Okay, thank you very much for listening. I'm very much looking forward to have your question. Thank you.